Welcome back. Today we'll talk about Chapter 19, which covers altered mentation, and we focus a lot on diabetic emergencies because that's one of the more common ways that we see altered mentation. So we're going to cover a lot of different presentations of altered mentation, what can cause it, but we are going to be focusing heavily, especially at the start, with diabetic emergencies. Alright, so starting off with some pathophysiology. Remember, this is the study of how the diseases actually affect our body. So, this should be a little bit of review at this point, but our normal consciousness is regulated in our brain, and it's a series of neurons that comprise the reticular activating system, otherwise abbreviated as the RAS. The RAS gives us, like I said, our consciousness. So it's what really helps us stay awake, helps us have conversations, pay attention to people, and it's what tells us when to go to sleep, so when to lose consciousness. This is what actually keeps us, us. It's what makes us alert, oriented, makes us aware of our surroundings, makes us interact with things. So this is what makes you, is your reticular activating system. So it is a very sensitive system, and if we have any changes in the supply to make energy for your reticular activating system, you're going to have a lot of issues with altered mentation. So first thing that the brain needs is oxygen. We've covered that several times already, that if you have low oxygen levels, one of the first signs that we see is altered mentation. So if you don't have proper oxygen, you get altered mentation. Second one is if you don't have enough glucose, then you won't have good mentation, because the brain takes an incredible amount of glucose to actually work properly. It uses up to 20% of your entire body's glucose supply goes to your brain. So if you do not have enough glucose in your bloodstream, you're going to have altered mentation happen very quickly. The last thing that you need is water. So if you are dehydrated, then you are going to have some altered mentation. So any changes to any three of those key elements in our body, and we're going to have altered mentation. So there are several other things that will cause altered mentation, but if you boil it down, any change in one of these things will cause a change in the supply of oxygen, glucose, or water. So trauma, so if you have a trauma and you're bleeding, you can't get proper blood to your brain, or if your brain is swelling, that can cut off blood flow. Infection, some chemical toxins, which we're going to talk about a lot in poisoning and overdose, which is 2 chapters from now, and anything else that might harm the brain tissue itself. So there are a lot of different causes of altered mentation. We're going to cover a lot of those today, but when it comes down to it, it's usually something that's going to be affecting your supply of blood, glucose, or oxygen, typically. So when we're assessing our patients with altered mentation, you first have to figure out, are they alert or not? So that's why we have the AVPU acronym. So that's alert, or if they're alert to just verbal stimuli, painful stimuli, or unresponsive. Remember, if someone's sleeping and you wake them up, they're alert. If it's just someone who simply needed to be brought attention to, they're alert. When they're not alert, this is someone that, say they're responsive to verbal stimuli. You shout at them, they open up their eyes, they look at you, they interact for a few seconds, and then they immediately go back to sleeping or altered mentation or something. So it's someone that you can't arouse for a long period of time. Same with painful stimuli, is you give them painful stimuli, they open up their eyes, they interact with you for a second, which might not be talking, it could just be moving their arms to the painful stimuli, and then they go right back to being unresponsive. So that's what we mean by the AVPU. We're not just saying, oh, they were sleeping and we had to talk to them to wake them up, so they were alert to verbal. No, that's someone who is alert. So the second thing we need to figure out, if they are alert, and only if they are alert, you have to figure out if they are oriented. And remember, we do this by measuring 4 different metrics. They have to be oriented to person, place, time, and events. So being oriented to person is knowing who you are, so they know their name. Place is they know where they are, so you can say, what city are you in, what street are you on, depending, if they're in their home, you can ask their address, or you can ask if they know that they're home. So you can say, what building are we in? If you're in the back of an ambulance, say, what type of vehicle are we in right now? The next one is time. Typically, you can go as broad as what year is it. So if you ask what year is it and they reply correctly, that's good. You can also get more specific, especially with people who should be oriented and you think that they aren't. So you can say, what month is it? You can sometimes say what day of the week is it or what day of the month it is, but I'm gonna be honest, there are a lot of times where I don't know that answer without checking my watch or something else to tell me that. So I do like month. Getting more specific than month, I don't particularly like all too much, just because a lot of people at baseline who are oriented might not know what day it is specifically. In fact, as I'm making this recording, I do not know exactly what day this is. I just woke up and I have not checked today's date, so I have a broad range, but I'm not sure. Another thing that you can ask, if it's someone who might not know the month because they just don't care about dates, you can ask them what season we're in. Are we in fall, summer, winter? You can ask them questions like that for time. You can make it appropriate based off of what you think the patient at baseline should know. And then events is, do they comprehend what's currently happening? And it is kind of hard to find out a good question to assess events because you have to think of something that everyone should know. So the question that we generally go with is, who is the current president of the United States? So that's usually a question that most people should be able to answer accurately if you live in the United States. There are some people who might not know that at baseline, but that covers the vast majority of patients we see. So those are the 4 questions that you ask. I will go on a personal note. In this particular area, there are some instructors that tell you to ask how many quarters make a dollar. And that's a very common thing I see. It's one of my pet peeves when people ask that, because knowing how many quarters are a dollar doesn't prove that you're oriented to person, place, time, or events. It says that you're oriented to simple math skills. And unfortunately, when we are talking about altered mentation, if they are oriented to person, place, time, and events, then they are alert and oriented legally. So if they don't know simple math skills, what are you going to say that they're not oriented to? Are you going to say that they have altered mentation because of that, even if they answered everything else right? So to me, it kind of seems like a pointless question because it doesn't tell us any key metric that we're looking at in assessing orientation. So that's just a personal note that drives me crazy in the field. So if you have a patient that is not alert and oriented, so we have any one thing missing in any of those questions, then they do have altered mentation. If they have altered mentation, do your best to find out what their baseline mental status is. The vast majority of people, their baseline mental status is alert and oriented. But there are a lot of patients out there, especially if you get to the elderly population or people who have developmental disabilities or even small kids, that at their baseline are not alert and oriented. They do not know what time it is ever. They do not know where they are ever. So if they are acting at their baseline mental status, then that doesn't really constitute as altered mentation. That being said, if they at baseline are not altered, they at baseline can't make decisions for themselves. So these are not patients that we should really be taking refusals on because they can't make that decision themselves. In the real world, if you have a patient that is at baseline altered and they do not want to go to the hospital and no one at home wants them to go to the hospital, say that they just lost their balance and fell down, they are injured, they just called you for a lift assist, no one there wants you to take them to the hospital, then use your judgment. If you really think that there's no injuries there, that they just need the simple lift assist, and everyone's in agreement that it's best for the patient to not go to the hospital, use your judgment. And if you have any questions, you can always contact medical control and ask them. So in going back to determining altered mentation, if they are at their baseline, then to us, they are not altered. They're just at baseline. So keep that in mind. So people with altered mentation are incredibly dangerous calls for us to be on, because people who are altered are unpredictable. And this becomes particularly dangerous for us with patients that we might see routinely. Say it's a diabetic patient who you've gone to several times, and he's always been alert and oriented, but now he's altered. He won't interact the same way that he normally does with you guys. So you might walk in thinking this will be a nice routine, pleasant call, and he's very violent and he doesn't know what he's doing. So this is where we really have to keep our guard up at all times, because we can't predict what patients are going to do, especially patients that we have experience with. It could be your own family member, and if they have altered mentation, they might get violent with you. So when you are approaching a patient, always consider the safety of yourself and your partner or other responders on the scene. If you need to back off, back off. It's okay if you walk in, you see someone's altered and violent, and you get away from the scene and wait for law enforcement to come in. And that brings us to our last point. If someone is altered and violent, do not be afraid to call for law enforcement. Sometimes you're going to need to have some sort of intervention until we get them alert and oriented, which might not happen with us. So you might have to have someone who is restrained the entire way to the hospital. So as we talked about at the start of the chapter, one of the biggest things that we see for causes of altered mentation is hypoxia, low oxygen levels. So if we see someone that has altered mentation, always start with thinking hypoxia. And so we always start to consider the possibility of an airway or breathing problem. So how do we fix that before we can diagnose it? Is we can give oxygen to these patients so that they have increased oxygen levels in their blood, which will hopefully fix hypoxia. So in our primary assessment, remember our goal in our primary assessment is to identify and treat life-threatening problems. So that's when we're considering oxygen administration. Again, you can't really go wrong with altered mentation. Number one, a altered mental status patient might not be able to tell you that they're having respiratory distress because they don't have the mental capacity to understand that. And also, we need to rule out the possibility that the altered mentation is being caused by hypoxia. So oxygen administration is something that you can generally be okay doing. Again, you can assess other things to find out if they're in respiratory distress, to make sure that they are breathing adequately for starters, but you can also assess lung sounds, make sure that air is moving in and out very well, and then you can assess an SpO2 level. If everything is checking out good and you have an SpO2 of 100%, you can think about not giving oxygen. But remember, our SpO2 can be tricked by different things like poisoning, such as carbon monoxide. So take everything into the grander scheme of things. If you have a patient that's outside and has been outside for a while, the chances of them having carbon monoxide poisoning are very, very, very slim. So take everything in the grander scheme of patient care. When you are assessing an altered mentation patient, be aware that they can very easily vomit, so take note of their position. If they are laying flat on their back, think if they vomit, they're going to have a hard time not aspirating. So be prepared to suction the patient and maybe move the patient to a lateral recumbent position, so on their side, or have them sitting up a little bit, depending on how altered they are. If they're unresponsive, sitting up is not really the best for them because they can't keep themselves up. So be alert to their proper position and be ready to suction if you need. When we go on to our secondary assessment, that's when we really get to thoroughly examine what's going on, same as any secondary assessment, but we need to thoroughly examine their behavior. So keep in mind that any altered mentation usually means that there's something very wrong going on in the body. And sometimes it's something very wrong that can be fixed easily. Like diabetics oftentimes can be fixed pretty easily, but it's something that is very wrong, and if left untreated, could lead to massive deterioration of the patient and death. So remember that when we assess our body systems and we get our full history, that might give us some clues about the cause of our altered mentation. Altered mental patients are kind of fun to assess because you have to be a detective. The patient is not going to tell you everything you need to know. You need to start looking around for clues to help you discover what's going on with the patient. So this is where we do a full, thorough assessment of the patient. We need to do our rapid physical exam of head to toe, and then try to find out any area that might be going wrong that will point us in the right direction. It's also critical that we survey the scene for clues, which also includes interviewing our family members and bystanders to figure out any history with the patient. If you have an unconscious patient at home and their family says they're a diabetic, you should probably initially think this is probably a diabetic call. Or if you have a altered mentation patient at home and the family says that they have an extensive drug use history, and you see drug paraphernalia there, so you see some needles, syringes, you see baggies of heroin, then you should probably think that this might be a overdose problem. So taking a look around the scene and talking to family and bystanders, which could include friends who know the patient, is huge to helping you figure out this mystery that you need to solve. So that being said, when we're looking for clues to the patient, look at their medications. This is why when we talked about general pharmacology, it's pretty big that we need to start learning the major drugs that people are on. Like I said back then, a lot of patients are on the same medications for the same problems. So if you start learning the really common ones that are prescribed to patients, it will help you figure out, well, the past 20 patients that were on Humalog had diabetes. So since this patient's on Humalog, they probably have diabetes. Again, when I said it in pharmacology, I'll say again, this comes with time and experience. I'm not expecting you to know massive amounts of patients at home medications by the time you're done with this class. This is something that when you're out in the field and practicing, keep your eye out for and continue learning about things. When you're done with this class, you are not going to know everything there is to know about being an EMT. I'm expecting you to continue your learning and education with experience. So take a look at their medications and try to figure out what are some common things that people with these medications usually have as their medical problems. You can take a look for medical alert bracelets. I'll be the first to admit that I'm one of the worst ones at doing that. I never think to look for medical alert bracelets. Usually after I treat the problem and they are conscious, alert, and oriented, they tell me, oh, did you see my medical alert bracelet? I'm like, nope, didn't even think to look. So that is something that I'm personally very bad at. But that does help us a lot. If you think to look for that, it will tell you a lot of the major medical problems that might cause the altered mentation. And then if you can't find the cause, if it's not blaringly obvious at you, then we just start going through our causes of altered mentation. And there are a lot of them. So this is why we really have to rely on our secondary assessment to try to help us eliminate some of them easily. But when in doubt, just start going down the list of things that you can't or haven't ruled out and see if you can do anything to rule them out. And we have a pretty comprehensive list in the next 2 slides. So your causes of altered mentation, we commonly refer to them as your H's and T's. The H's are words that start with H and T's are words that start with T's. So some causes that we go through, and as you can see, it's a very extensive list, which is why we really hope that your assessment can help rule a lot of these out. And a lot of these can be ruled out very quickly. So first one is hypovolemia. So that is low blood volume. You can include hypovolemia with bleeding, or you have dehydration, which causes a low amount of plasma in your blood, which will cause low levels of blood. So anytime you have low amounts of blood, that can cause altermentation. Next one is hypoxia, so low oxygen. We've talked about that quite a bit. Next is hyper or hypokalemia, so that's high or low potassium levels. That is something that's pretty hard for us to rule out in the field. The only time that we have any clue that this might be a hyper or hypokalemia patient is someone who has a history of renal failure. So it's someone that you, on your assessment, see and they have external fistulas placed into them, which that's something that we'll talk about in hematology and renal emergencies, our fistulas, and why that might give us some clues. So that's the only real thing that we at the EMT level can do to rule in or rule out hyper or hypokalemia, and we can't definitively say that they're in that. You need blood work to decide that. Next one is hyper or hypothermia. So that's high or low temperature. We can assess that by using a thermometer. Next one is hyper or hypoglycemia. So that is high or low blood sugar levels. We can determine that by taking a blood sugar. Next one is hydrogen ion, which is pretty much trying to make it an H word, but it stands for acidosis. That's when our body chemistry is off, so we become too acidotic. That's something that is hard for us to determine in the field, but one of the biggest ones that we look at for a cause of that is someone who has a history of infection. So they might be going into what's called sepsis, which we're actually going to talk about later in this chapter. So someone who has a hydrogen ion problem is someone who is becoming acidotic in their blood. Their blood is becoming too far low on the acid-base balance scale, so your pH scale. Moving on into your T's, you have tension pneumothorax, which we talked about quite a bit with respiratory emergencies. So if we have tension pneumothorax, that will cause a oxygen supply problem, which will cause altermentation. Tamponade is something we're going to talk about with trauma. Tamponade is when you have, just a basic explanation, is when you have pressure pushing in on your heart. So if you have pressure surrounding your heart, then you're going to not have the heart pump as effectively. If you don't have the heart pump as effectively, can't move blood, you can't get all the critical elements to your brain, so you're going to have altermentation. Next one is thrombosis. Remember we talked about thrombosis as being a blood clot that will detach and float around through your body, and it can lodge and cause a acute myocardial infarction or a pulmonary embolism. So either one of those will cause a oxygen supply problem and or a heart problem, which in turn causes a oxygen supply problem to your brain. And the last one is toxins. Toxins are, very simply put, like alcohol or drugs, something that can affect your body and that will oftentimes cause altermentation. If you think of a drunk person, they have altermentation. So that's a very long list of things that can cause altermentation between your H's and T's. Some of them are very easy to rule out. It's very easy to rule out hypo or hyperthermia. You take a temperature. It's easy to rule out hypo or hyperglycemia. You take a blood sugar level. So a lot of them can be ruled out very fast, but it's a long list of things to go down, and there are some things that we can't definitively rule out. We can look for clues, like in the hypo or hyperkalemia, we can look to see if they have a fistula, but we can't definitively rule that out. We can say that our suspicion is lower, but until we do labs, we can't figure that out for sure, and in the field, we can't do labs. So keep all that in mind and try to figure out what the most likely cause is. It could be more than one thing happening at once, but generally one thing is a primary drive that causes this altermentation. So just a quick side note about pediatric patients. Kids don't have the same baseline mental capacity as adults. They might not be able to answer questions appropriately at their baseline. For example, a 4-year-old probably doesn't know who the president is. A 4-year-old might not know where they are if they're not in a familiar place. They're not going to know that they're in this town. They just know, I'm not home, I'm not at my friend's house, so they don't know exactly where they are. And a 4-year-old might not know the year. So this is where we really need to tailor our questions to make them age appropriate, and sometimes we won't be able to fully assess some of the questions. So this is where we look at the patient's general level of activity and their interaction with us. A 4-year-old should interact with us and probably be a little scared sometimes. They might be very interactive, but look at them compared to what a normal 4-year-old might do around us, or a normal 2-year-old or 3-year-old. They should either be very happy to see us and want to play with us, or they might be very scared. But if they don't really show any interest in the fact that we're there, so they just kind of, we walk up to them and they don't really change their mood at all, that might be an indication of altermentation. So this is where we need to ask our parents, or if it's a caregiver, ask them, are they acting differently than normal? Are they at their baseline for what you know of them? Because the parents are going to have a very good idea of what their normal is like. And so if they differ anything from the normal, a parent will pick up on it very quickly and a lot quicker than we will. So that's where it's very important to be talking to our parents. So if you think about it, what kind of information about a patient's altered mental status might you obtain from a scene? That can be medications, it can be medical alert bracelets, it can be talking to family and friends, and it can be just doing a quick head-to-toe assessment of the patient and maybe seeing something going wrong with the body system. Then how might bystanders help you identify the cause of altered mental status? Very simply put, they can usually tell us what happened, and if they know the patient, then they can tell us history of a patient. But a bystander will usually be able to tell you that this happened very fast, or this happened very slow, or maybe this walked up on a person and they saw them like this. So even just knowing how fast or slowly altermentation came on might give us a good clue as to what's happening with the patient. All right, so now moving on into diabetes. Diabetes is quite a common disease that we see, and it's one that will cause a lot of problems with our patients. And fortunately, sometimes it's something that we can easily treat at the BLS level. So these are patients that we can actually significantly help, usually at the scene, and we can sometimes fix them entirely to where they don't need transport to the hospital. So at this point, you guys should know the role of glucose in your body. Glucose is another term for sugar. So if we eat sugar, our body converts it into glucose. Glucose is what's needed to make ATP in your cells. ATP is what makes energy in your cells. It's what gives the cells the power to do what they actually do. So without ATP, your cells can't function. It is a huge cause of altered mental status, and like I said at the start of this chapter, the brain consumes 20% of all the glucose in your body. It is a very hungry area for glucose. So if you have any dip in your levels of glucose beyond normal, you're going to see some pretty quick altermentation. This is a very, very quick response that your body will have because your brain can't make the ATP needed. If your brain can't function properly, you're not going to have everything you need for consciousness. So the glucose molecule in the bloodstream is very large. So that poses two different issues. First is that it won't get into the cells without something to aid it going in. It's just too large to diffuse into the cell on its own. And if it can't get in the cell can't use it. So we need something to help let the glucose molecule get into the cell. That is called insulin. I'm sure you guys have heard of insulin before. We're going to talk about that in the next couple slides. And it also poses another problem because if it's just sitting in our bloodstream and our bloodstream gets down to the capillary level, which, as you remember, can get as small as 1 cell wide. If glucose is in there and nothing will move it, it can get stuck inside your capillaries. And this is where typically the insulin will combine with the glucose to let it into a cell on the other side of the capillary. But if there's no insulin to move the glucose out of your bloodstream and into cells, it will just stay there, and it won't be able to move through your capillary, and it causes an obstruction. So this is why you might hear people saying that diabetes is a disease of the microcirculation. And that's because if in diabetic patients, you oftentimes have too low of insulin levels, and we're going to talk about that extensively in the next couple slides. But if you don't have enough insulin, then you're going to have glucose in your body that can't get into the cells, so it's just going to stay in your bloodstream, and we can't have that key of the insulin move it out. And if it stays in the bloodstream for such a long period of time, then you're not going to be able to flow blood past that capillary, and your cells beyond that capillary are going to not be able to get perfused. If those cells can't get perfused, they become what we call necrotic, because we can't get oxygen to them and we can't remove the waste products from them. If enough cells become necrotic, we're going to see that in a patient. And this is especially more profound in areas that have lower pressure at baseline from your blood. So a lot of times it's going to be in your feet. Your feet don't have good circulation as it is, just because it's so far away from your heart. So you're going to start to see necrotic tissue in your feet. So these are the patients that will have black toes, toes that obviously haven't been perfused. And this is, if it's left alone for such a long period of time and you get such large amounts of necrotic tissue, you'll have large areas of your body that are going to die. And if you have areas of your body that die, we need to remove them. So this is why our diabetic patients, especially long-term diabetic patients that don't take care of themselves, they don't follow the medications they're supposed to take, they start having toes cut off or feet cut off. I'm sure you guys have seen people that have diabetes that have amputated feet. That's because it's become very necrotic, because we can't move that glucose cell through the body. And the glucose molecule is very large. So this is kind of putting it all together as to why we see some of the things that we see. And we're going to talk about this a lot more in the next couple slides as to why that happens. So insulin is produced by the pancreas. It then enters the bloodstream, it combines with blood sugar, and then it goes into the cell. So that's a little diagram of how that happens. So I like to think of it as the cell is a locked door, and you need a key to let the glucose in. So insulin acts as the key to open up the door into the cell. So without that key, you can't get into the cell. So your body has a balance between your sugar intake and insulin production. And that sugar intake insulin production balance is what allows our body to use the glucose that we eat effectively. So it recognizes that we have eaten or taken in glucose somehow, so it triggers the pancreas. Okay, we need to produce some insulin. And so we should have a nice balance of glucose comes in, insulin gets produced. When we don't have that balance, then we fall into issues that we see with diabetes. So we do have two types of diabetes. So diabetes type 1 is your pediatric onset. So if you think we have type 1 and type 2, if you think type 1 is first, it's what happens first to people. So it happens to kids. This is pediatric onset. Now, adults will have it, but this is just determining when it first came on in the body, so when they're first diagnosed with it. Almost every single time, if that came on when they were a kid, then it's a type 1 patient. So this is where the pancreas, the cells don't actually function properly. So we just, at baseline, don't have insulin produced normally. So if we don't have enough insulin produced, we can't use it to move the glucose, which is a pretty big problem. So the fix for this, since the pancreas physically can't produce the insulin, is these are patients that will have insulin shots. So we make insulin for them, and they inject themselves with insulin typically after they eat, so that we are artificially placing insulin into their body. So these are ones that we oftentimes see on insulin pumps. Just because they take insulin doesn't mean that it's type 1, but it's a very good indicator that it might be a type 1. Now, I know we're talking about type 1, type 2. This is important for us to understand the differences between, but in the end, we treat them both the same. So if we have altermentation, no matter the type of diabetes, we're still treating it the same. So keep that in mind, that just because they're type 1 doesn't mean that we treat them differently with the same complaints that we see with type 2. So type 2 is what we consider adult onset. So this is where we have enough insulin production from the pancreas, but our body doesn't utilize the insulin well anymore. So if we can't utilize the insulin well enough, then we can't move the glucose into the cells. So this is usually caused by a patient not having a good diet or enough exercise. So these are patients that are usually very obese. They have a lot of fat to them, and they usually have very, very poor diets consisting of a lot of sugar. So your body has been so overloaded with sugar for such a long period of time that it's lost its ability to do its glucose intake and insulin production balance. And your insulin just starts to become more ineffective just because we've had such high levels of glucose for a long period of time. So your body's just tired of the high levels of sugar. So this can be oftentimes treated with medications that will help activate the insulin, so it helps the insulin be used better. But it also can be controlled through proper diet and exercise. If we have someone who loses weight by exercising and they start eating not very high glucose level food, so they stop eating a bunch of candy and drinking a bunch of soda, and they have salad instead for a long period of time, they lose weight, then their diabetes can be very, very well controlled. Some people might say that their diabetes is cured, but once you have a diagnosis of diabetes, it doesn't really ever go away. It's just very, very, very well controlled. And sometimes to the point where you don't need medication to control it anymore. It's just controlled with your diet and exercise levels. These patients can be placed on insulin because sometimes the insulin produced in their body just is so ineffective that no matter what, they can't get their glucose levels under control. So these are people that will have to use synthetic insulin that they inject into their bodies. So like I said, in type 1, it's a good indication that they might have type 1 diabetes, but it's not the definitive indication because there are plenty of patients that have type 2 diabetes that have to get insulin shots. So, going into actual diabetic emergencies. With diabetic emergencies, we're looking at either too low or too high of blood sugar. So too low of blood sugar is called hypoglycemia. So the causes behind hypoglycemia mean it's essentially that there's too much insulin and not enough sugar in the body. So we can have the causes of, if they inject insulin, they injected too much insulin. So they put too much insulin in their body and it burned through all the glucose in the body, and now there's no more glucose left. Other causes is a diabetic patient does not eat, so they don't intake insulin, or excuse me, they don't intake sugar. If you don't put sugar in the body, you won't have sugar in the body. Next one is if a diabetic overexerts themselves, so they are too physically active, they burn through all the blood sugar in their body, but they still have the artificial insulin in there. So you'll have altermentation because you burn through all the blood sugar. Some less common causes is when a diabetic vomits. So they ate their meal and they vomit it right back up, which means that the glucose couldn't actually get into their body because it got ejected out through their mouth. So if it couldn't enter their bloodstream, they might not have enough blood sugar in their bloodstream. And then another cause that, again, a little bit less common, but absolutely can happen, is if they increase their metabolic rate. And the body increasing your metabolic rate, so that's the rate at which you use your blood sugar, a lot of times happens in illnesses. So if you think about your body fighting off an infection, you feel tired and you feel like you don't want to do anything, but that's because your body is working double and triple time to try to fight whatever's inside your body attacking you. And if your body is working that hard to fight, it's still making an incredible amount of ATP at the cellular level because it needs your cells to be performing optimally. And so if you're making a lot of ATP, you're burning through a lot of glucose. If you burn through a lot of glucose, you might not have enough glucose left in your body, and you're going to fall into a hypoglycemic state. So those are some of the very common causes of low blood sugar. So the signs that we look at for hypoglycemia, it's usually a very fast onset. This is not something that takes days to happen. This is something that will happen within minutes, maybe even an hour. So very rapid onset. You usually have high altered mentation. So a lot of times our hypoglycemic patients might mimic someone who might be drunk. So someone who's stumbling around, who's acting erratically, who is slurring their speech. Think of someone who's drunk, and that's oftentimes one of the first signs of hypoglycemia. They might get down to a level of being unconscious because they've gotten that altered, but our first few signs are someone who might look like that. You look at pale and sweaty skin. That's because you're going into a state of shock. So you know all the rules behind shock. Your body starts compensating. So you get pale and sweaty skin. You also get tachycardia. You might have rapid breathing because your body is in a state of shock. And those are some of the very simple things that your body does to compensate for it. You might get to where a patient will have a seizure. And we'll talk about seizures a little bit later in the chapter, a patient who is seizing, it happens because their brain is not getting enough glucose to it, and if it doesn't get glucose to it, it starts to not act right and starts to misfire, and when we have our brain misfiring, that's what causes seizures. So when we have low blood sugar, like we said before, our brain cells need a lot of glucose, and so they get starved of that glucose. So first clues that we're looking at is the altered mental status. Like I said, this can go into unconsciousness. This happens more frequently when someone goes to bed and while they're sleeping, their body goes into a hypoglycemic state. So this is someone who might get called by their spouse because the patient's acting a little weird, and they were woken up because the patient was breathing weird or they're moving around weird. And then this is someone that we might not be able to wake up at all because the onset happened while they were sleeping, so it's taken so much time to recognize it that they are now completely unresponsive. It's a very common thing that we are called to. Usually if it's during the day, a patient can feel that their blood sugar levels are going low and they're going to feel a little uneasy, and people will see that drunken state where they're acting weird, and so we can catch it before they go unresponsive. But if they went to bed, we won't be able to catch those signs beforehand, and so it's going to progress into being completely unresponsive. If we leave this untreated, this will cause permanent brain damage because your brain cells get starved and they're going to die off. And if it's left untreated for a very long period of time, and by very long I just mean a few hours, then it can cause death. If your brain can't function because it doesn't have enough glucose, then it can't keep your body alive. So hypoglycemia is a very big medical emergency. It's something that we can relatively easily treat either at the BLS or the ALS level, and it's a very fast turnaround. These are patients that will go from unresponsive to completely alert and oriented within seconds. But if left untreated, it's very dangerous. It can easily cause death. So, our treatment of hypoglycemia: first, support your ABCs. Again, if it gets so bad that they're unresponsive and their brain cells have been deprived for so long, they might have some breathing problems going on. They might need ventilatory support. So make sure that you support your airway and breathing and your circulation if needed. Ensure you're seeing safety, because these patients who are altered can become violent very quick. If you have the ability to assess your blood sugar levels, please do it, because that will be a nice definitive way to find out that their sugar is low. If it's appropriate to the patient, administer oral glucose. Remember, oral glucose is only able to be administered if the patient is conscious enough to follow instructions and able to swallow, because we don't want to be shoving this oral glucose into these patients' mouths and just have it drip down into their airway and have them aspirate. Request ALS if needed. So if they are someone who can't take oral glucose for some reason, or you've given oral glucose and it's not working, that's something that ALS can step in on. ALS will be able to actually start an IV and give glucose directly into their bloodstream. So that's something that's very useful, but we want to start with the BLS treatment if we can. So if you can treat them at the BLS level, even if you have ALS there, we're going to be treating them at the BLS level, because we don't want to be going any more advanced than we absolutely have to. So keep in mind that hypoglycemia can mimic the symptoms of several different emergencies. First one, that's not listed in here, is being drunk, which is not really an emergency, but that's something that we might overlook. We might just think, oh, this patient's drunk, and just transport them to the hospital for being drunk. And then we get them to the hospital and find out that their blood sugar level is 40. So they're acting like this because their blood sugar was too low. Now, they could also be drunk on top of it, but you can't overlook the fact that they have altermentation and just think, oh, they're drunk, and not think diabetes. So that's the first thing that we overlook a lot. Other things that can mimic the symptoms of, or that hypoglycemia can mimic symptoms of, is stroke. So a lot of people will think that someone's having a stroke when it's really just a blood sugar problem. So that's why any of our stroke patients, which we'll talk about stroke a little bit later, any of our stroke patients, we need to assess blood sugar levels on. Next one is shock. That's because hypoglycemia, people call it diabetic shock for a reason. Your body is going into a state of compensating. So like we said in the symptoms, you'll have tachycardia, you'll have rapid breathing, you'll have pale and sweaty skin. You'll think that, oh, this person's in a state of shock, and it's really being caused by low blood sugar levels. And also overdose. A lot of patients we might think are overdosing on something, but really they're unconscious and presenting like this because they have hypoglycemia. So blood sugar levels is something that we need to assess on a lot of our patients, and especially any patient that has altermentation, you should be taking a blood sugar level on to rule out hypoglycemia. So moving on into hyperglycemia. So this is high blood sugar levels. So this is a lot of our patients that are diagnosed with diabetes. It's because they have high blood sugar levels and their insulin's not being effective. And a lot of, especially our type 2 diabetics, this is something that is hard for them to manage. So at baseline, they might be hyperglycemic. And hyperglycemia as a whole is a little less serious than hypoglycemia. It's a little bit easier to catch and to treat in the initial stages, but if left untreated, hyperglycemia can become a life-threatening emergency, which we'll talk about in a little bit. So, some causes of high blood sugar: stress, illness, increased oral intake. Now, I know that I said in hypoglycemia, illness might cause the patient to have low blood sugar levels. That's because illness will cause your cells to be working very hard, so you're going to have a increased metabolic rate, which will cause a drop in blood sugar because your cells are going through it so quickly. But your body has backup systems in it, and it will store glucose, like your body stores glucose as emergency reserves. And so if your body senses that you're fighting off an illness, it says to itself, oh, we need extra glucose so that our cells can produce more ATP, it can make more energy. And so your body will say, all right, let's release these stores of glucose into the body. And so we have an increase in blood sugar from that because your body is literally putting more glucose into your body. So you that will cause a rise of blood sugar, so that causes hyperglycemia. Obviously, the increased oral intake, if you're eating more glucose, you're going to have higher blood glucose levels. And then a decrease in insulin. So that's oftentimes caused from your body's inability to produce insulin or inability to use insulin properly. And it might be caused by a diabetic who just doesn't give themselves enough insulin that their body needs. So that will cause a decrease in overall insulin levels. And if we don't have that key to let our glucose into the cells, we're just going to have it sitting in the bloodstream and we're going to see hyperglycemia. So, like I said, hyperglycemia is not a sudden onset. It's not something that's going to happen in minutes or hours. This happens over days and even weeks. If we catch it in the early stages, we can usually treat it properly. We can just have the patient return to whatever they're doing normally. So if they're eating a lot of high sugar foods, we tell them to stop eating these foods, let your body work through all the glucose that you put in it, and you should return to normal. But if you leave it untreated, it just climbs and climbs and climbs and climbs, then it really needs intervention. And it usually means that the patient needs to be on a constant insulin drip in the hospital, and that actually has to be done in the ICU. So these are patients that will typically be admitted to the ICU. That's any indication of how serious this can get, that they have to be in an intensive care unit when they get very high. So in regards to hyperglycemia, keep in mind that glucose loves water. Glucose acts like a magnet for water. So when we have someone who has high blood sugar levels, you're going to start to see three different signs. We call it the three polys. It's polyuria, polydipsia, and polyphagia. Polyuria is excessive, so poly just means excessive. Polyuria means excessive urine production. And that's because we have all the glucose in the body that when it hits the kidneys, it's going to attract an excessive amount of water to the kidneys. If there's a lot of water in the kidneys filter that out and produce urine. So that's why we have high levels of urine production during hyperglycemia. The next one is polydipsia. Polydipsia is increased drinking. So it's someone who has a ton of thirst, and they're having so much thirst because your body senses that we need more water to mitigate this glucose. So your body wants to drink as much water as possible so that we can have this glucose attract that water and balance out our bodies. And then we have polyphagia. Polyphagia is increased hunger. And this kind of seems counterintuitive. It says, you think you have so much sugar in your body that you shouldn't want to eat more because that's just going to increase the sugar levels. Well, if you have a ton of blood sugar in your bloodstream, that means that the blood sugar is not getting into your cells because insulin's not doing its job to let into the cells. Your cells are actually being deprived of glucose. It's going to trigger your brain saying, oh, we're not getting enough glucose. We need to mitigate that. We need to get more glucose into our body. Primary way of doing that is by eating. So you're going to have a compounding effect because not only do you have high blood sugar levels to start with, you're also going to want to put more blood sugar into your body, which still can't be used. So those are three classic signs of hyperglycemia: are polyuria, polydipsia, and polyphagia. So when someone is hyperglycemic, they start to become very dehydrated. That's because, like we said, glucose attracts water, and when it hits the kidneys, it's going to have so much water hit the kidneys that the kidneys wants to put it out. So if you excrete so much water, you're going to become dehydrated very quickly. You're also going to have excessive waste products released into your body system because your cells are not operating the way that they should, because they're not getting the glucose into their cells to operate properly. So if we have excess waste products released in the system, that starts to cause a process that we call diabetic ketoacidosis. So that's abbreviated DKA. So breaking that word down, diabetic, so this happens in diabetes, and then keto is ketones, which are levels of sugars, and then acidosis, because your body goes into an acidotic state, so your pH balance is disturbed. So when we have someone in diabetic ketoacidosis, which this is the end stage of hyperglycemia, this is the medical emergency part that we were talking about with hyperglycemia. You're going to have someone who has altered mental status. Now, again, this is something that happens very slowly over time. So this is not someone who goes to bed fine and wakes up a couple hours later with profound altered mentation. This is something that happens over days or even weeks. You're going to go into a state of shock because you are dehydrated. If you're dehydrated, you don't have enough blood volume, so you can go into hypovolemic shock. You have deep, rapid breathing. We call that Kussmaul respirations, and this is incredibly deep and very fast breathing, and that's because the body is trying to get rid of all the ketones in it. And one of the ways that the body tries to do this is it tries to expel it through your respiration. So your body's trying to get as much air movement as possible to try to take the ketones from your body and have it diffuse across into your alveoli and then breathed out. And the body can do a little bit of this. So when you see this, you're going to have an acetone odor on the breath. Acetone is a ketone, and the acetone odor is like a very fruity smell. So if you have someone that has a very fruity, sugary type smell when they're breathing, and they're breathing very deep and very rapidly, you have to think that they're probably in diabetic ketoacidosis. And keep in mind, deep, rapid breathing is called Kussmaul respirations. Oftentimes that is a test question. So Kussmaul respirations are deep, rapid breathing associated heavily with DKA. So going into our patient assessment, again, ensure the scene is safe. These are patients that have altered mentation, so scene safety is a continual thing you have to reassess. When you do your primary assessment, you have to identify your altered mentation and then protect any ABCs that might be compromised. When you perform your secondary assessment, find out what's going on with this present episode. So find out if it was a fast or slow onset, how long it's been going on for, if there's any mechanism of injury or any trauma. If you're altered, the chances of you falling are very high because you can't walk straight. So find out if you have to protect the C-spine. Find out if the patient's had a seizure or if they have a fever. Fever will indicate infection, which will raise your suspicion for blood sugar problems. Do your standard sample history. Find out if they have a history of diabetes. This is where you can try to look for medical alert bracelets. You can talk to family, bystanders, and then you can look for medications. And one place that people always forget to look is the fridge. Most insulins have to be refrigerated, so that people will keep them in their fridge. If you don't look in the fridge, you might miss insulin. And then we need to check blood sugar if you are equipped to do so. Again, our blood glucose meters measures the amount of glucose in the bloodstream. A lot of patients will have these at home. They do it themselves, so they'll be aware of what their normal readings are. It's measured in milligrams per deciliter of blood. So that's milligrams of glucose per deciliter of blood. There are some readers that will read high, so just HI, high. Some might say low, abbreviated LO. These are manufacturer specific, And this means that they can only assess up to X amount of level. A lot of meters that EMS uses will only assess up to 5, 6, or 700 for their blood sugar. So if it's over that amount, it will just read as high. So you won't know what their actual levels are. You just know it's above this level. So that's why it's very important that we know what brand meter you use and what the capacity of it is. So when it says high, you know it's above this level because of this meter. Again, that can change based off what meter you have. So that's something you have to find out with your own individual agency. So keep in mind that the normal range of blood sugar in the body is 80 to 120 milligrams per deciliter. Also keep in mind that a lot of diabetic patients, especially type 2 diabetic patients, may always be hyperglycemic at baseline. If they are not following their treatments and they are not compliant with their medications, then they might always be hyperglycemic. So if you find someone who is hyperglycemic when you're assessing their blood sugar, so say that you get 275 for a blood sugar level, which is very high, ask them what their baseline is, because their baseline might be 350. So if their baseline that they get every single day, and they've had that for years, is 350, and you get 275, that's actually lower than what they normally operate at. So everything is relative to the patient's baseline. So if you get a very high reading, ask them what their normal is. And most diabetics, because they check their blood sugar routinely, will know what their baseline is. So in hypoglycemia, we see this in patients that have a blood sugar of less than 60 milligrams per deciliter. And this is in a symptomatic patient. So this is someone who has altered mentation or has another sign that we might think is indicative of hypoglycemia. So anything that's below 60 and they are not symptomatic, we should have them eat something to raise their blood sugar a little bit more. But we are treating with our medications if they are symptomatic and below 60. And keep in mind, their mentation will vary based off of the individual patient. Some people will be altered at 75 milligrams a deciliter. Some might be conscious, alert, and oriented at 30. I had an uncle who was a very brittle diabetic, and he would be talking to you completely fine at 30. And most patients will be completely unresponsive at 30. So it will vary from patient to patient, especially based off of how often they are hypoglycemic. So keep all that in mind, but no matter what, if it's below 60, we should do something to have them raise their blood sugar. Oftentimes that's just simply eating, but if they're symptomatic, that's when we're giving them our oral glucose to raise that up. Anything above 140 is considered hyperglycemia, but we don't really get too worried about it until we get above 400. So that's where we have to have ALS evaluation. We absolutely have to have transport to the hospital. Oftentimes patients that have blood sugars in the 200s still should get transport to the hospital, especially if that's not normal for them. But we aren't incredibly worried about it. It's not someone that we are requesting our ALS links for. We're doing interventions and requesting ALS links for people who have a blood sugar greater than 400, and especially if it's for a prolonged period of time. And that's because we will see that lead to DKA, which we talked about, all the bad things that happen when someone's in DKA. Here's a blood glucose kit. So we have several different things. Again, these are manufacturer specific of what they might look like, but the different items right here is your glucometer. So glucometer is how it's spelled, but glucometer is how it's pronounced. So this is what's actually going to read the blood sugar for you. Right here is a thing of strips, so that pops up, the lid pops up, and there will be strips that get inserted right here. That's what you touch to the blood to have it read. Right here is an alcohol prep because we need to clean any area that we puncture. So we need to make sure it's sterile, or as sterile as we can get. You should also have 2x2s and or band-aids in here to stop the bleeding after we get the blood that we need. And right here is a lancet. Lancet is what we use to actually puncture the skin with a needle. So it's a spring-loaded mechanism. This right here is the safety. You remove that safety off, and then the needle will be coming out of here. So you just push that against the skin, and then you push this button, which activates a spring, which will quickly shoot the needle down and then back in. It's going to be retracted for good. It can't fire more than once. So those are the different components to a glucometer. And again, manufacturer specific. Be sure that you use the one at your own agency and you know how everything works with the specific one that you're going to be using. So occasionally we can fix a mild hypoglycemia and minor altermentation by just giving the patient something to eat. Because if we give someone something to eat, their body's blood sugar levels will rise. Keep in mind, when they're altered, they might be to a point where they can't swallow, and if they can't swallow, anything that you give them orally might make them aspirate. So do not let them aspirate because you're trying to shove food or liquids down them. And then, like I said, when we have someone who has very low blood sugar, so it's below 60, and they're symptomatic of it, we're giving them our oral glucose. So oral glucose, remember our dose is 15 grams. It's administered orally. We pack it between the cheeks and gums if able to, because it can actually get into the bloodstream through there a little bit before they actually swallow it. And always, again, make sure that they are able to swallow. So these are patients that have altermentation, but they are awake enough to swallow. If they do not have altermentation and their blood sugar level is below 60, that's where we want to try to use their own food at home. So have them eat something of substance. It's usually something that has high carbohydrates in it, and that should fix our problem. So after you do oral glucose, you have to reassess them. So and keep in mind, oral glucose works very slowly. It has to be digested for it to get into the bloodstream. That's why we try to pack it into the gums if available, or if you're able to. So if it's been a long period of time, so like 10-15 minutes, and you don't see any improvement at all, consider a second dose of oral glucose, or have them try to get other types of food into the body. So that's where you have food or drink that you can help give them. Something that I love for my diabetic patients is peanut butter and jelly sandwiches, because the bread is high in carbohydrates and the peanut butter is high in complex carbohydrates. Complex carbohydrates take a longer time to metabolize, which means that you have the bread and also the jelly, which is high in sugar. So the bread and jelly will be quickly absorbed into the bloodstream, but then you have the peanut butter that takes a long time to absorb into the bloodstream. So you have both initial high levels of sugar coming in, and then you also have a prolonged slow stream of sugar to keep them okay for a long period of time. And then another benefit is a lot of people who eat a peanut butter and jelly sandwich will want something to drink. So if we get them something to drink that's high in sugar, such as like orange juice, which a lot of diabetics keep orange juice around in case if they have an issue, they are going to want to drink that orange juice in order to keep their mouth a little moist when they're eating the sandwich. So it's a nice combination of, we can get a lot of sugar into them, both short acting and long acting, and it stimulates them to want to drink, which will get even more sugar into them if you pick a sugary drink. So this is something that I personally want my patients to do regardless of if the oral glucose worked or not, because again, our oral glucose acts fast, which I did just say it's a slow onset, but in the grand scheme of digestion, it acts very fast, but it wears off very fast. So we need to replace that with something that's going to last longer. So we give the oral glucose, make it better in the short term, and then we have them eat the stuff that will make them better in the long term, so that when the oral glucose wears off, it's replaced by what they've eaten. If you cannot fix the hypoglycemia on your own, giving them something to eat, something to drink, you can call for an ALS evaluation and or transport them to the hospital. And If they have other complaints, absolutely transport them to the hospital. But if their only complaint is hypoglycemia, this is something that we should be able to fix at the scene. And if we fix at the scene, chances are they're not going to want transport to the hospital because you're going to fix all their symptoms. So if they request transport, absolutely transport to the hospital. But this is something that fortunately we can generally fix everything that needs to be fixed. So they won't want transport to the hospital because they're feeling completely better. So comparing hypoglycemia and hyperglycemia against each other, because both of them will produce altermentation, so we do need to know the signs that say high blood sugar or low blood sugar. So keep in mind, hyperglycemia has a slow onset, and hypoglycemia tends to come on suddenly. In our hyperglycemic patients, they will often have warm, red, and dry skin, while your hypoglycemic patients have cold, clammy skin, and usually pale. So hypoglycemic patients, again, follow the signs of shock very quickly. Hyperglycemic patients do not for skin condition. Then their breath. Again, our hyperglycemic patient has Kussmaul respirations and might have acetone odored breath, so the fruity smell on your breath. Not every patient has this, but if you see this in a patient, that's a very strong sign that they might have hyperglycemia. So if you're diagnosed with diabetes, most diabetics live very long, healthy, happy lives. Most diabetics are controlled easily by diet, exercise, and maybe some medications. But if you do not control your diabetes, if you're not compliant with your medications, it can wreak havoc on your body. Remember, like I said at the start, diabetes is seen as a disease of the microcirculation, because if we have high levels of blood sugar because we can't get the insulin to move the blood sugar into our cells, then we won't be able to move our blood through our microcirculation, our capillaries, and if we can't do that, we become very necrotic, which will lead to amputations. So it can be a very devastating disease if left uncontrolled. It's also a big risk factor for heart disease. One of the main reasons for this is if we have this huge molecule flowing around the body that can't get into the cells because we don't have enough insulin to do that, the body is going to react by trying to pump harder, to have the heart pump harder to get more pressure to move that blood around more, because the blood has all these huge sticky molecules of glucose flowing around it, so your heart's going to be working harder. So if your heart works harder, it's going to get weakened over time. So that's one reason why we can have heart disease. And also, if we have excess glucose floating around our vasculature, it gets into our coronary circulation, which it should be to perfuse our heart and to get the glucose into the cells of our heart. But if we have a high level of it, it will cause our circulation in our heart to not be as good. And so if you don't have good circulation in your heart and you have large molecules backing things up, you're going to have more tendency to have more fatty deposits not move as well, and so they're going to stick to each other. If you have fatty deposits stick to each other, that's what causes clots in your heart, which causes acute myocardial infarction. So diabetes can be a very bad thing for your heart. It can be a huge risk factor for heart disease, which is why when we talked about cardiac emergencies and we talked about gathering history of patients, one thing that we need to figure out is if they have a history of diabetes, because history of diabetes increases your chance for heart disease significantly. All right, so moving into the other causes of altered mentation. There are a lot out there. Like I said at the start, diabetes is a huge one that we see a lot of problems with, but there are several other causes of altered mentation. So remember your H's and T's that we talked about at the start of this presentation? We're going to review them again in the next 2 slides. We also have our S's. Our S's are general things that might cause altered mentation. So, and we're going to talk about all these a little bit later. So we have sepsis, which is infection, seizure, stroke, syncope, which is a loss of consciousness, and shock. We also have toxins, which are in our H's and T's, and that's a big thing that we look at. But we're going to be discussing that in poisoning and overdose. So that's chapter 21, we discuss toxins. So remember our H's and T's, we have hypovolemia, hypoxia, hyper or hypokalemia, potassium levels, hyper or hypothermia, hyper or hypoglycemia, hydrogen ion, which is acidosis, tension pneumothorax, tamponade, thrombosis, and toxins again. So going back into our S's now. So the first S is sepsis. So sepsis is when we have an infection happening in our body can go into a septic state. So sepsis is a collection of problems associated with our response to infections. So this happens when the body's response to infection moves from where the actual infection is, and it kind of gets more widespread throughout the body, so it becomes a systemic problem. This leads to septic shock, which is a form of distributive shock because it's distributed throughout the entire body. We'll talk about that a little bit later. If someone goes into septic shock, it is very, very, very deadly. Once they actually reach the state of shock, it is a 40% mortality rate, which means 4 out of 10 patients who reach septic shock will die. So that is an incredibly high level of mortality, which is why it's important that we identify sepsis and we identify septic shock very early and we get the treatment very early, because the longer that we leave sepsis untreated, the higher that mortality rate goes. So, talking about septic shock, the bacteria from the infection, wherever it is, can enter the bloodstream and then spread through the entire body. This means that the body is going to try to do its normal response to the infection throughout the entire body. So that will manifest itself in 2 different ways. It will suppress the body's release of a chemical called vasopressin. Vasopressin essentially keeps your vasculature constricted. It's what presses your vasculature. So if you can think of vasopressin, it presses your vasculature, keeps it constricted, keeps your blood pressure where it should be. If you have an infection in your body, one of your body's first responses is its inflammatory response. So it's when your body is fighting an infection, you get inflammation. If you think of, if you get bit by something, say you're bit by a mosquito, one of the first things you see is swelling to that area. And that's because your body is fighting the infection that entered your body through the bite. So your inflammatory response causes the movement of fluid to go from your capillaries to your interstitial space. That's what inflames the area. So if we have the inflammatory response throughout our entire body, it's going to tell all of our fluid to move out of our bloodstream and sit into our interstitial space. So if we have a combination of your body can't release vasopressin to keep your vasculature constricted, and then we also tell our body to move all of our fluid outside of our vascular space into our interstitial space, you have a 1-2 punch of vasodilation, because nothing's keeping it constricted, and what we call leaky capillaries. So not only do we open up our container, but we also take fluid out of our container. So we have very, very low blood pressures. And that is what causes the high mortality rate with septic shock, because we have very low blood pressure, and if we don't have enough blood pressure, we can't perfuse any of our body. So, like I said, it's a very dangerous form of shock that will lead to death very quickly. So, when we're assessing our patients, some signs that we look for that indicate severe sepsis, first we need to have a suspected infection in the body. Some of the most common infections that we see, especially in the elderly, are UTIs. Those are urinary tract infections. So it's an infection that gets in through your urethra, and it will cause a inflammatory response. It's a very, like I said, very common infection, but it's a very serious infection that can happen. There's also other infections. Another common one is pneumonia. So it's an infection that manifests itself inside your lungs, or you can have any number of infectious diseases happening. That's a whole day in itself. I could talk about infectious diseases. Just pneumonias and UTIs are some of the common ones we see, especially in the elderly population. So other signs that we see altered mentation because we have decreased perfusion. You see fever. That's your basic body's response to infection, is it wants to increase your body temperature to try to kill off the infection that can't stand the increased temperature. You also have increased heart rate and increased respiratory rate. That's your body trying to compensate. You'll have the low blood pressure from the vasodilation in the leaky capillaries. You also have decreased capillary refill time because you have low blood pressure, you have low perfusion. You're not going to be able to refill the capillaries as quickly. Our treatment, we have rapid transport to the hospital. These are patients that we are rushing to the hospital. Use your lights and sirens to get them to the hospital. Try to have an ALS intercept because ALS can try to start to stabilize the blood pressure a little bit. At the EMT level, you want to support the ABCs and do your general treatment for shock. Our general treatment for shock is oxygen administration, keeping the patient warm, and laying them down flat. That's proper positioning, laying them down flat. Used to be that we would raise the legs up. That's called the Trendelenburg position, but now we are just laying the patients flat. And also, pre-notification to the hospital that you are suspecting sepsis. That is key. That way, when you get to the hospital, they are ready to treat the sepsis right away. Because, like I said, sepsis is a very deadly disease that we need to intervene very quickly. That's the only way that we can raise the survivability rate, is to treat it quickly. So notify the hospital that you're coming in with a suspected sepsis patient. So moving on into seizures. So seizures is another very common thing that we see with patients. So seizures is when our normal brain function gets disturbed by something. It could be injury, it could be infection, or it could be disease. It could be a disease that a patient will have that causes this a lot. But no matter what, it's a disruption in the normal electrical activity in the brain. And so the electrical activity starts to become irregular. I like to describe it as your brain just starts to misfire a lot. So it's just shooting random signals very, very fast because it can't have a regular activity for a little bit of time. So that the irregular electrical activity leads to what we see in seizures. Seizures, we will have a sudden change in sensation, behavior, and movement. If you think about the typical seizure, it's someone shaking uncontrollably. That's the irregular electrical impulses coming from the brain to the muscles saying to just convulse abnormally. So a seizure is not a disease in itself. You can't say that I have the disease of seizures. It's the symptom of a disease. So a lot of patients will have a disease called epilepsy. Epilepsy is a disease and it causes the seizures. So it causes that symptom. But seizures in itself is not a disease. It's a symptom of something happening. So we have two different types of seizures. You have a focal seizure or a partial seizure. That's a seizure that will only affect one area of the brain. And so you might only see the symptoms in one area of the body. The patient might not lose consciousness with a partial seizure. So that's maybe a patient has uncontrolled shaking of their arm or their leg or something like that. That is a partial seizure. Then you have, much more commonly, a generalized or grand mal seizure. That's where the entire brain is affected. And you will have a loss of consciousness with the patient. These patients will not be conscious at all. They will not respond to any stimuli at all. These are patients that when they're in a generalized grand mal seizure, you can give them as much painful stimuli as you want and they will not respond to it. I'm not saying you should do that. I absolutely give them a little bit of painful stimuli, see if they're responsive, but don't give them everything that you have and continue to do it and cause an injury because you've been trying to give them so much painful stimuli. quick assessment of their mental status by doing a little bit of painful stimuli and then move on. So in the generalized seizure category, you have what are called tonic-clonic seizures. So this is our picture perfect seizure. This is what everyone thinks of when you think of seizure. Tonic means that the body gets rigid, and clonic means that the body jerks around. You can have just a tonic seizure, you can have just a clonic seizure. More commonly, we have both happening. So you have tonic and then clonic. So the body will become very, very rigid for like 30 seconds, and then you go into your clonic phase where it's shaking around. And that's the more typical representation. So we call it a tonic-clonic seizure. So again, that is unconsciousness with a lot of major motor activity that we can see. These are our typical seizures. When someone has a tonic-clonic seizure, they will have a postictal phase. Postictal phase is a time where they are not actively seizing anymore, but they're still very altered. They might still be unresponsive, but they are very altered. I like to say that's the time that the brain is resetting itself. So if the slide says, think about the brain rebooting itself. So the brain turned off. So if you think about a computer turning off and then you restart it, it takes a bit to return to normal activity after you turn the computer back on. So this is a slow period of regaining consciousness. Other signs that we look for in tonic-clonic seizures are patients will be incontinent of urine and or bowels during the seizures. That's because they lose all sense of organized muscle control, and muscles are what keeps your urine and your bowel movements inside. So you'll have incontinence that you see in a lot of tonic-clonic seizures. So a term you might hear thrown around are called an aura. An aura is a feeling that the patient has just before a seizure will happen. Usually an aura is the same for a lot of patients. Well, they'll have the same aura every seizure they have. A aura between patients could be very different. So it might be a specific smell that they have, or they might get a sound in their ears, or just a different feeling that they have. And this happens right before a seizure, and it might happen before every seizure they get. So sometimes people call 911 because they feel their aura, and so they know they're going to have a seizure, and so they get us started for the aura. So it's something to take very seriously if someone tells you that they are feeling their aura, because that means that they probably will have a seizure. So you need to be prepared for them to have a seizure. This is something that we should have ALS started for, because ALS will be able to actually give them medications to stop the seizures. So we have a ton of causes of seizures. So we'll go through this list real quickly. A lot of the causes you'll see are things that can affect how the brain will normally function. So hypoxia is a cause of seizure. Stroke, which in turn leads to hypoxia, it's cause of seizure. A traumatic brain injury, so where we have something traumatic happen inside the brain where it won't be able to function because it gets hurt. Toxins that affect how the brain functions. Hypoglycemia, as we talked about, we're interrupting the glucose supply. A brain tumor, so that's something that can put excess pressure on the brain, and it will affect how the brain actually normally functions. Any congenital brain defect that affects how the brain functions. Infections will sometimes affect how the brain functions, especially if the infection gets into the brain itself. Epilepsy, which is a disease that causes seizures. Eclampsia, which we'll talk about a little bit in OBGYN. Eclampsia is something that we can see in pregnancy. So we'll talk about that a lot more later, but it's something that happens in a pregnant patient. Heat stroke, so if the brain just gets too hot. And in turn, fever. Fever is the probably number one, I don't know the actual statistics, but it's probably the number one cause of seizures in pediatrics. And that's because pediatrics don't have the ability to sweat. or they have very reduced ability to sweat. So especially your like 2 or 3-year-olds cannot sweat. So if you can't sweat, you can't regulate your body temperature as well. So a fever will be a lot more dangerous because you can't lower your skin temperature by sweating, and then the fever will commonly spike very high, and if it spikes very high, your brain starts to fire irregularly because just gets too hot. It can't function well if it's too hot. So fevers in pediatrics is a very common cause of seizures, and we call it a febrile seizure. So febrile seizure is something we see a lot in pediatrics, and we'll return to that during our pediatric day. So keep in mind, not every seizure is going to present as your typical textbook seizure. Not all of them are generalized tonic-clonic seizures. Your partial seizures, again, that's your focal seizure, will be an uncontrolled muscle spasm or convulsion while the patient is fully alert. Also, we have something called pseudo seizures. And I kind of joke around because the actual meaning of pseudo is fake. So pseudo seizures are fake seizures, if you break that word down. These are patients that present as a generalized seizure, but it's been proven over and over and over and over again that they do not have the irregular brain activity associated with an actual seizure. These are patients who are having psychosomatic seizures, so that's being generated by their consciousness. They essentially are faking their seizure. So if a person tells you that they have a history of pseudo seizures, know that that's not the typical seizure that you see with a presentation of having a regular brain activity. These are patients that their brain is acting perfectly fine, but their body is shaking. So it's usually something that's consciously controlled. Again, you have your typical tonic-clonic seizure, and then you can also have an absent seizure. We call that a petite mal. So if you think tonic-clonic or generalized seizures are grand mal, these are petite mal, so small seizures. This is something that presents mainly the patient will just be staring off into space. They won't have any realization of what's going on around them, so they won't respond to it at all. They're just going to be staring off and not be aware of their surroundings. A lot of them go unnoticed. Usually the people who can pick up on this are ones who are very knowledgeable about the patient. So these are family members might say, oh yeah, they had a absent seizure because I've seen this several times. That's how it presents. You see a lot of absent seizures in people with developmental disabilities. So that's where we most commonly see absent seizures happening. And that's why it's very hard to pick up on, because people with developmental disabilities aren't normally alert and oriented a lot of the times. So when they're just staring off, you could just think that they're just thinking about something or concentrating on something, but they could in fact be having an absent seizure. So there's something called status epilepticus, and that is an incredibly life-threatening condition. So status epilepticus is defined as 2 or more convulsive seizures in a row without regaining full consciousness, or a single seizure that lasts more than 10 minutes. This is someone who is seizing continually. This is a massive emergency. This is an emergency because a lot of times, well, number one, your brain's not firing regularly, which is an emergency in itself, but a lot of times in seizures, with the brain not firing regularly, you can't breathe because your brain's not stimulating your muscles to breathe. So if you are not breathing for a long period of time, that's a problem. So this is a very life-threatening emergency. This requires a high priority transport, and it's something that we need to do immediately. So this is not something that we're fooling around with on scene. We are transporting them immediately and trying to get an ALS intercept if you can. ALS can sometimes stop the seizure with medication, like I said, but sometimes you give that medication and they're still seizing. That's a very dangerous form of status epilepticus, is one that we can't stop with our normal medications. So this is a very life-threatening emergency. Status epilepticus, that's when someone does not stop seizing for a long period of time. So when you're assessing seizure patients, some questions that you want to be asking is, what was the person doing before the seizure started? Then what happened during the seizure? Especially think of traumas. So did the patient fall down? If they were standing up at the time, they probably fell, so you need to think about C-spine precautions. Was there any other trauma that may have happened? Did they convulse and move around and hit something that they shouldn't have hit? That may have caused trauma. How long did the seizure last for? Usually you should have a seizure last less than 5 minutes. And you shouldn't have them going straight back into another seizure. That's where we see status epilepticus. What did the person do after the seizure? Did they immediately regain consciousness, or were they postictal? Did more than one seizure happen? Then find out, does the patient have a history of seizures? This will be a big clue into your patient care. If they do have a history of seizures, did this present as a typical seizure that they've had? Before today, when's the last time they had a seizure? If they had a seizure last week and they have a seizure every single week and they had one today, that's a little less concerning than someone who hasn't had a seizure in 10 years. Do they have a history of multiple seizures in one day? That might tell you if they have a high chance of going into another seizure in your care. Are they on medications for this? Most patients who have a history of seizures are, but then find out, are they compliant with those medications? Do they actually take what they're prescribed? And especially, do they normally take it and then they forgot to take it today? That might explain why they had their seizure. If you are present and a seizure happens, make sure that the patient is lowered to the floor or ground. Hopefully they're on your stretcher at that point. If they have restrictive clothing, it's very rare that they do, but they have restrictive clothing, loosen it up so that they aren't restricted by it. Make sure that they don't have any objects around them that might hurt them. Protect them from injury, but don't hold them. That was a very old school way of thinking, is hold them down so that they don't hurt themselves. Just let them seize it out. Yeah, as I joke around, I say let them shake it off. So don't hold them down, but prevent them from hurting themselves. So if they are on a bed and they're shaking and they're going towards falling off the bed, move them so they aren't going to fall off the bed. And then support their ABCs to the best of your ability. Again, these patients might not be breathing. So if they are not breathing and they won't get out of the seizure, so the seizure is lasting for a very long period of time, try your best to ventilate them. Not the easiest task in the world. So do it to the best of your ability. Once the seizure has ended, make sure the airway is protected. A lot of patients might vomit either during or immediately after a seizure, so make sure that the airway is protected. If there's no possibility of spinal injury, put them on the lateral recovery position so that if they had or do vomit, it's easier to drain out of the airway. If the patient is cyanotic, ensure that the airway is open and provide oxygen and possibly artificial ventilations. This is because, again, the patient might not have been breathing during the seizure. If you aren't breathing for a long period of time, you're going to have hypoxia, which you'll see cyanosis. Also, it's critical that we assess our blood sugar level. We want to do this, number one, because hypoglycemia can cause a seizure, but also your body uses an incredible amount of energy when you seize. It's equivalent of, I believe it's like running uphill for 2 miles for every one seizure or 1 minute of the seizure that you have. So it's in a very, very short period of time, you burn through a ton of glucose, which means you can seize and then actually put yourself into a state of hypoglycemia after you seize. And these patients who are postictal and so have altered mentation, you're thinking, oh, they're just postictal, they're going to come back. But really, they're postictal and they put themselves into hypoglycemia, so they're not going to come back because they don't have enough blood sugar to come back. So it's very critical that we assess our blood sugar levels in anyone who is seized. A patient who's breathing adequately, again, may need oxygen by non-rebreather or nasal cannula. If they injured themselves during the seizure, treat the injuries, then transport these patients and request an ALS intercept. So moving on into strokes. So stroke in its broad sense is oxygen deprivation of the brain tissue, and that will cause death or injury of the brain tissue because it's not getting its proper blood supply, so it's not getting its proper oxygen levels. So two ways that this can happen. You can either have an artery get blocked, so it can't supply anything beyond the blockage in the artery, or you can have a blood vessel rupture. If the blood vessel ruptures, it can't get blood beyond where the rupture is. So we're either looking for a blockage or a rupture of a blood vessel. So we have two different conditions that will cause stroke-like symptoms. The first one is a cerebral vascular accident. So cerebral is brain, and then vascular, an accident. So something's happening to the vasculature of the brain. That is your typical stroke. So that is an actual stroke. So cerebral vascular accident, otherwise said as CVA, is your typical stroke. You also have a transient ischemic attack, or a TIA. So CVA or TIA is how we say it. A transient ischemic attack is when the brain is ischemic, so it's lacking oxygen, and so it's going to show the exact same signs as a stroke. This is called a mini stroke because these symptoms actually resolve. So the ischemia is typically caused by small little clots in the brain that then get resolved on their own. So these are patients that will present exactly like a stroke because your brain's not getting the oxygen needed because of that small little blockage, but then that blockage gets dislodged or dissolved, and your brain returns to normal activity. And this can last for a considerable amount of time. It can last for a couple hours. So these are patients that we need to treat like a stroke. It's just sometimes it might not actually be a cerebral vascular accident. This is not a determination that we can really make in the field, but if someone is presenting as a telltale stroke and then their symptoms suddenly resolve on their own, even in front of you, that's probably the cause, is a TIA. So the signs of stroke that we look for, it's one-sided weakness. That's a very common sign. So you'll have full use of your right side of your body, but you'll have no use of your left side of your body, or vice versa. You might have difficulty speaking or the complete inability to speak. The complete inability to speak is called aphasia. Remember, A means without, so without speaking. And the difficulty speaking is called dysphagia. So dys is always difficulty, so dysphagia. So difficulty or inability to speak. You might have facial weakness. We call that facial droop. That's where one side of your face can't have muscular tone to it, so you see one side drooping down. And it's a less common complaint, but you might have someone complaining of a splitting headache. Splitting headache might be caused by a ruptured vessel that is bleeding into your brain and putting a lot of pressure on your brain. So you might have someone with a very intense headache, but again, that's a less common sign that we see. So some non-traditional signs that we'll see with strokes: altered mentation is one of them because your brain's not getting perfused. Dizziness, so someone who just has sudden onset of dizziness, you have to think possibly stroke. Numbness, weakness, or paralysis, typically on one side of the body, but it could be widespread. It's just usually on one side of the body. Incontinence, so loss of bowels or bladder control. Impaired vision. Very high blood pressure usually, but high blood pressure in itself is not usually a sign of stroke. It's just an associated sign that we see with other signs and symptoms. Difficulty breathing. Again, this is something that we see associated. Nausea and vomiting is something we see associated. Seizures. Unequal pupils. Loss of vision in one eye. And unconsciousness. So it does say it's uncommon, but you can see someone who goes unconscious, just not usually the first thing you see. This is something that will be a progression. If you have a stroke and it's left untreated, is they will become unconscious over time. So most of our patients we see are conscious though. So Some of these are supporting signs, like I said, and some of them can be the only sign. So like dizziness can technically be the only sign that you see in some types of strokes. But most of these are supporting signs, and our classic signs of stroke are usually what we see in almost all of our stroke patients. So the facial droop, the difficulty speaking, and the weakness on one side of the body. So those are the typical signs that we see in most strokes. So it's pretty hard to communicate with a lot of stroke patients. A lot of them have altermentation. They don't know that this is happening to them. They think that they are just normal, and they can, a lot of times, like I said, one of the major signs is difficulty or lack of being able to speak back. So a lot of these patients can't communicate back with you a lot. So again, going back into TIAs, it's where small clots will temporarily block circulation to part of the brain. You'll see these patients present just like normal CVAs. And then when the clot breaks up, gets dislodged, the symptoms will resolve. Usually you will have a complete resolution of symptoms without treatment within 24 hours, but a lot of times it can be within 1 hour. It can be within a couple minutes. So it's usually much sooner, but you should have complete resolution of symptoms within 24 hours. Again, we have to treat this like a CVA until proven otherwise. We do not have the capabilities to differentiate between these two, but just keep in mind that if someone that's presenting as a CVA suddenly gets much better in front of you, think this is probably a TIA instead. CVAs will not resolve in front of you. They will not get better without treatment. TIAs can. So when we're assessing our patients, we use what's called the Cincinnati Pre-Hospital Stroke Scale. So Cincinnati Pre-Hospital Stroke Scale will assess your ability to smile. So if you smile and one half of your face will not smile, that's how we see facial droop. We assess our speech. Our speech, we ask them to repeat this specific phrase: "You cannot teach an old dog new tricks." When they say that, you need to make sure that they are able to actually repeat it, and then you look at how their speech is, if they're slurring their words. So if they're slurring their words or they can't repeat that specific phrase, then you have a positive finding on the pre-hospital stroke scale. A lot of people try to say different phrases because they don't like that phrase, but that phrase is specifically designed to target key areas of your brain to repeat that phrase back to you. So saying "you cannot teach an old dog new tricks," exactly that is what you're supposed to do when you're assessing in the Cincinnati pre-hospital stroke scale. Next one is arm drift. So we do this with two different tests. First, you have the patient squeeze your fingers as hard as they can, and you should have one side that's squeezing very hard and another side that won't squeeze either as hard or at all. You then have the patient close their eyes. You bring both hands up with their palms facing up, and you hold them there, and with their eyes closed, you let go, and you count to about 5 inside. So if you let go and during that count of 5 that you're counting internally, one arm goes down or drifts away, then that's a positive find. A lot of times in big strokes, that arm will just immediately drop down to the ground. So those are the 3 areas that we're looking for in a Cincinnati pre-hospital stroke scale. A positive finding in any of those means it is a stroke until we prove otherwise. So any positive finding means stroke. Here's a great example of a patient that has some facial droop, and you can see that his tongue is going off to this side. So the tongue being deviated to one side, especially the side of the facial droop, is a good sign that the patient's having a stroke. And you can see his eyes are kind of staring off and they're a little bit blank, which is a good sign of stroke, that he can't comprehend what's going on because his brain is compromised. So when we are treating patients, maintain their ABCs. Sometimes it does get compromised, especially if the stroke is affecting the areas of the brain that support your airway and breathing. To keep the patient calm, Administer high concentration oxygen if indicated. We used to do high concentration oxygen for every stroke patient, but this is only if indicated. So if we have some sort of respiratory compromise or your SpO2 level is below 92%. Rapid transport to the hospital is key. Time matters. So request ALS, but do not wait for ALS. There's very little ALS can do for a stroke. In fact, a lot of states, strokes are considered BLS calls because they need you to get the patient to the hospital faster. The only thing ALS will really do for your typical stroke is put an IV in. An IV is not going to save the patient. So, yes, it's nice to have ALS because then we can have that step already done for the hospital so things can move a little bit quicker. And also, if the patient deteriorates, ALS can manage the other symptoms, but do not wait around for ALS to show up. This is someone that you are having ALS intercepting you on the way to the hospital. These are patients that I say, catch me if you can. You should be on the way and have ALS meet you on the way and cut you off on the way to the hospital. Also, it's incredibly important that we assess our blood glucose level. That's because our blood or a hypoglycemic patient may present exactly like a stroke. The altermentation that comes with hypoglycemia might actually present like a stroke. So make sure that you have your blood sugar level assessed and make sure it's not a hypoglycemia problem. As far as transport goes, make sure that we are transporting any stroke patient to a hospital that has the capabilities of managing a stroke patient. In the Syracuse area, those hospitals are Upstate and Crouse. St. Joe's is a recent addition to stroke care, but Upstate and Crouse are comprehensive stroke centers. So those are our two primary stroke centers still. You can technically bring a stroke patient to St. Joe's, but St. Joe's is not a comprehensive stroke center, at least at the time of this recording, they weren't. The hospital at bare minimum needs to have a CT scanner, and again, comprehensive stroke centers have the abilities to treat a patient that has a stroke beyond just doing a CT scan of their brain. And when strokes come on, time is critical. The longer brain goes without oxygen, the quicker it will die, and the quicker that we will have long-lasting complaints. So symptoms that last beyond just the initial stroke. This is where we have what are called deficits that happen for the rest of your life. So time is critical. Typically, and this number changes every couple of years, it's actually getting longer and longer, which is good, but typically we have a window of between 3 and 24 hours from the start of symptoms. That's how long we have to have them get treated. So someone who may have had symptoms start 4 hours ago might not be able to be fully treated anymore. So our window is below 3 hours at a minimum, and sometimes we can extend that to 24 hours depending on the patient. Like I said, this window is changing constantly, but if any patient is below 3 hours from the onset of symptoms, they should be able to get treated for the stroke and have resolution of their symptoms. When we are assessing these patients, it's critical that you know the exact time of their onset of symptoms. If you can't find out the last time of onset of symptoms, we have to know the last time that they did not have the symptoms. So if you have a patient who lives on their own and family checks in on them, and family was there at 8 p.m. the previous day, and they came in at noon on the next day, and the patient's having stroke-like symptoms, your last known well was 8 p.m. on the previous day. Even though the stroke may have started an hour prior, so it started at 11 a.m. that day, our last known well is 8 p.m. the previous day. So that is a critical measure that you need. And that's something that you need for the hospital. They will ask you over and over and over again what the last known well time was. If you can, try to document the contact information of the person that can give you the time of onset so that they can talk to the hospital. And also, when we're taking care of these patients, it's critical that we give pre-notification to the hospital. So this is where we're calling ahead and talking to the hospital directly saying, I have a suspected stroke patient. These are the complaints. this is the last known well time because that's what determines the window that we can treat the patient in. And these are our vitals, including blood sugar. So those are all things that you need to have and tell the hospital before you get there. So this is a critical step, is pre-notification to the hospital. So moving on into dizziness and syncope. So these are very, very, very common complaints that we are called to, dizziness and syncope. It could be one or the other. Remember, dizziness in itself could be a sign of stroke. So they can indicate a serious or life-threatening problem, just like dizziness is a sign of a stroke possibly. It's not the only sign, and just because a patient's dizzy doesn't mean that they are having a stroke. It's just a sign that they could have. And a lot of times, dizziness and syncope, it's impossible for us, ALS, or even doctors to diagnose the true cause of what happened. So dizziness means different things to different people. It's a very subjective term. Some things that can cause dizziness, one thing is called vertigo. A lot of patients will have a history of vertigo, and that's the sensation of surroundings spinning around you. Usually these patients also have a lot of nausea and vomiting because everything's just spinning around. It causes them to be very nauseous. It's like being on a constant amusement park ride that's just spinning you around in circles. After a while, you're going to become nauseous and vomit. One of the tests that we can do for vertigo is if you have the patient looking straight forward, so you put your finger out straight in front of them, and then you tell them to keep looking at your finger and turn their head from side to side. If their dizziness gets much worse when they do that, that's usually a positive sign that it probably is vertigo. It's not your only sign, and just because they have that doesn't mean they do have vertigo. It's just a common sign that you will see in vertigo. Another complaint you might see is someone who has lightheadedness. So that's someone that might or has a feeling that they might be passing out soon. That if they feel really lightheaded and dizzy, and that means that they probably are going to lose consciousness soon. So syncope is the medical term for losing consciousness, passing out. So I don't want to hear you guys say passed out anymore. It should be syncope. So a syncopal episode is passing out. So it's a brief loss of consciousness, and they spontaneously recover. So they pass out and then they recover, they become conscious without any intervention. It's usually pretty short. It's usually only a couple seconds. It can extend to a couple minutes, but it's usually several seconds. A lot of patients who have a syncopal episode can feel it coming on. They're going to feel lightheaded and dizzy and feel like they're going to pass out, and then they do. So a lot of our syncopes can be caused by different things. So we can have a cardiovascular cause to our syncope. So that could be our heart is either beating too fast or too slow, which will cause decreased cardiac output. If we have decreased cardiac output, we have decreased perfusion to the brain. Our brain's solution is to make you pass out. Another huge cause of syncope is called a vasovagal syncope. That's when our vagus nerve, which is one of our cranial nerves, gets stimulated, and our vagus nerve is essentially responsible for slowing everything down in our body. It's what brings us down from being really hyped up. So one of the biggest things that it does is it slows our heart rate, and it causes widespread vasodilation. So if you have someone who's at normal body function and you stimulate your vagus nerve, it's going to say, okay, we need to slow down our heart rate and dilate our blood vessels. If we're already normal, though, we then take our heart rate and we plummet it well below what we're supposed to have it at, and then we also take our blood pressure and we tank it. And so that stimulation will cause you to lose consciousness because we can no longer perfuse our brain. And this is something that once you lose consciousness and the vagus stimulation's over, your body will reset back to normal and it bounces back relatively quickly. So this is a very common form of syncope. One of the easiest ways that we can stimulate our vagus nerve is by bearing down. So someone who is having a bowel movement and they're bearing down to try to have that bowel movement will lose consciousness. This is why we're called a lot to people who pass out in the bathroom, because they had vagus stimulation. Another way to stimulate it is having some sort of hard exertion happen. So if someone who passes out at the gym, it's usually because of a vasovagal episode. And another one is a sudden flash of pain. So someone who just suddenly had a lot of abdominal pain or felt like they really needed to vomit or have diarrhea and they're trying to hold it back will lose consciousness from a vasovagal episode. So like I said, this is a very common form of syncope. In my personal experience, the majority of my syncopes I go to are caused by a vasovagal episode. So you can also have hypovolemic causes. So if you have low fluid or blood volume, you will have someone who passes out, especially if they are attempting to sit up or stand. Some people at baseline, when they stand up too quickly, might feel really lightheaded and dizzy. This is same kind of concepts of just you have a low blood volume or low fluid, so you're probably a little dehydrated. One thing that we can do to assist in our assessment of hypovolemic causes is do what's called a orthostatic blood pressure. So that's if you have someone who's sitting down or laying down, you take their blood pressure right then, and then you have them stand up and you immediately take their blood pressure afterwards. If their blood pressure suddenly dropped after they stood up, that's a sign that it's a hypovolemic cause, usually from dehydration. So that's usually a good telltale sign that the patient is very dehydrated. If someone is bleeding, it might not be obvious that they're bleeding, so it could be internal bleeding. So always think hypovolemic cause when you have someone who has a syncopal episode, even if you don't see signs of massive bleeding. Just remember, we can be bleeding internally that you can't see. You can also have metabolic and structural causes. So that's where we have some sort of change to our brain, and our brain will cause us to lose consciousness. That's what we spent most of this chapter talking about, is that. Sometimes you might have inner and middle ear problems. That especially causes dizziness, and if it gets very bad, it can cause syncope. Hyperventilation is another one. Someone who's having a panic attack and is breathing really, really, really fast can actually breathe off too much carbon dioxide. If you breathe off too much carbon dioxide, it changes the chemical balance of your blood, and your brain doesn't like that. You need to have a certain amount of carbon dioxide in your body to maintain your acid-base balance. So your brain's solution to that is to make you pass out, because especially if you're consciously hyperventilating from some sort of anxiety cause, if you lose consciousness, you can no longer consciously tell yourself to hyperventilate. You're going to start breathing at a normal rate again, which will then reset your body's blood chemistry. You can also have environmental or toxicological causes. So alcohol or drug intake can make you pass out. That's pretty obvious to most people nowadays, especially with alcohol intoxication. And then there's a bunch of times where we don't know the cause. So about 50% of the time we can't pinpoint what our cause is, which is a large amount of patients. So it's very hard for us to definitively say what causes syncope, so these are patients that we should be transporting to the hospital for further testing to find out what actually caused the syncope. Because like we said earlier, a syncopal episode is indicative of something bad that happened in the body, and we need to figure out what that was. So when we're assessing these patients, make sure that you identify and treat life threats, especially if they are currently unconscious. Find out what we think might have caused the unconsciousness and treat that if we can. You need to ask them if they're conscious, have they ever had this happen to them in the past? How does this compare to when that happened? If they say that, oh yeah, I've passed out while on the toilet about 3 times every single year, and this is exactly how this presents for me, that's a little bit less concerning than just this random 24-year-old male who was walking and then just suddenly lost consciousness. It never happened before. And then when they say that they feel dizzy, say, well, what does dizziness mean? So is everything spinning? Do you feel like you're spinning? Like what? Describe the dizziness to me. Ask them if they had any warning signs that was going to come. So if they lost consciousness, say, did you feel lightheaded or dizzy, or did you feel anything before it happened, or just suddenly come on with no warning? How long did this last for? This is something that you probably can't ask the patient. You have to ask bystanders. So find out, were they unconscious for a couple seconds, a couple minutes? Find that out. What position were you in when it occurred? This is important to think of trauma. If they were standing and this happened, they probably fell. So find out what position they were in. If they were laying down, they probably didn't have any sort of trauma. And then find out, are they on any medications for this type of problem? You need to find out if they have any other signs or symptoms. Again, find out if they fell or have any other trauma that happened to them. Did anyone witness involuntary movements of extremities, like a seizure? So find out, was this someone who just passed out, or did they actually have a seizure? And some people will call you and say, oh, well, their eyes rolled in the back of their head, so they must have been having a seizure. That happens with normal syncope a lot. So just because the public says that they had a seizure doesn't mean that they necessarily did. Have them explain what they saw, what they felt like they thought was the seizure. And then find out, how are they feeling now? Did the complaints that led to the syncope subside? Especially if it was someone who had a vasovagal episode, so they bared down on the toilet and they felt really lightheaded and dizzy, and then they passed out, and now they're fine. So find out, how are they feeling now, or if they still have those complaints, you might be thinking, oh, they might lose consciousness again. You have to be prepared for that. As far as patient care goes, administer oxygen if appropriate, call for ALS, loosen tight clothing if it's appropriate, lay the patient flat, and if the patient refuses to lay flat, that's not a end-all be-all treatment. And then to treat associated injuries that the patient may have incurred from a fall, and then assess your blood sugar level. Make sure that that wasn't the cause of them passing out. Typically, it's not going to be the cause, because then they wouldn't have regained consciousness. That's not something that we generally see in hypoglycemia, but we do need to assess our blood sugar level. So shock is another cause of altered mentation. It's because it's hypoperfusion, means that the brain's not getting enough oxygen, and so it's not going to function properly. We have talked about shock over and over and over and over again, so I'm not going to spend really any time on that today. If you need to review shock, there's plenty of other presentations that you can see that we discuss shock on. So when you ever have someone who has a seizure or syncope, think, is this a symptom of a larger problem? Is something else causing this? If it's a seizure, was it caused because of hypoglycemia? Was it caused because of trauma? Was it caused because they have a history of epilepsy? Same with the syncope. What caused this, and is this just a symptom of a larger problem that we need to treat? So moving on into some chapter review. Remember that diabetic emergencies are usually caused by poor management of the patient's diabetes. Most people who are diabetic lead long and happy and healthy lives. Diabetic emergencies are often brought about by hypoglycemia or low blood sugar. The chief complaint of hypoglycemia is altered mentation. Whenever a patient has an altered mental status, a history of diabetes, and can swallow, you should be administering oral glucose. Seizures may have a number of causes. Assess and treat for possible spinal injury, protect the patient's airway, and provide oxygen as needed. You should gather information about the seizure to give to hospital personnel. A stroke is caused when an artery in the brain is blocked or ruptured. Signs and symptoms of stroke commonly include altered mental status, numbness or paralysis on one side, and difficulty with speech. For stroke patients, ensure an open airway and provide supplemental oxygen. Determine the exact time of onset of symptoms and transport promptly. Dizziness and syncope may have a variety of causes. In the case of syncope, administer oxygen, loosen clothing around neck, and if patient can tolerate, raise them flat. Do not raise their legs up. We are not doing that anymore. and then treat any injuries and transport. Remember to determine if the patient's altered mental status is being caused by hypoxia. In a patient with a hypoglycemic emergency, determine whether the mental status will allow the administration of oral glucose. Assess the seizure patient to determine the need for artificial ventilation, and determine when the symptoms of the stroke began. At this point, you should be able to list the chief signs and symptoms of a diabetic emergency. You should be able to explain how you can determine a medical history of diabetes. You should explain what treatment may be given by an EMT for a diabetic emergency and the criteria for giving it. Should be able to explain the care that should be given to a conscious and to an unconscious patient with suspected stroke. Should be explain the care that should be given to a patient who has experienced dizziness or syncope. So a 62-year-old male is witnessed to have a tonic-clonic seizure. You find him actively seizing. His skin is pale and moist and slightly cyanotic. What's the immediate treatment needed? Okay. So with this patient, you need to prevent him from having any injuries from the seizure, so make sure that he's not going to injure himself. Try your best to give supplemental oxygen and to ventilate the patient because his skin is pale, moist, and slightly cyanotic, which means he is not getting enough oxygen. But again, during the actual seizure, it might be hard to actually get this stuff on him, but do your best to do that. And also, you should be requesting ALS to intercept you to treat the seizure, and then transport rapidly. So that brings us to the end of this chapter. I know there's a lot to discuss. This covers a big portion of the calls that we go on, and we kind of just briefly talked about all these things. There's so much more material that we can go into with all these different causes of altered mentation, and it is very important that we have this down. You know, again, this is the bare minimum that you guys need to know, so feel free to do more research on your own, review the parts of this lecture that you may have not gotten the best understanding of. And please, please, please feel free to reach out to me with any questions. So, until next time.